Hello, everybody. It's an honor and a pleasure to be here among friends. It's wonderful to see old faces from many years ago. As Maurice introduced me, I am from Egypt originally. I've been living in New Orleans for the last 26 years. This is an interesting venue for me because right here in 1995 is where I met my wife when she was a periodontal resident at NYU, and she was a colleague of Edgar Shar, who's now the program director. So Edgar, Margarita sends her best. I'm going to go over some philosophies that some may agree with, some may disagree with, especially after the wonderful technology that we've just seen in with the past two speakers and the partial extraction therapy with the socket shield technique that has been really gaining a lot of ground in the last few years and is very tempting to use based on the knowledge. However, we are where we are today because we stand on the shoulders of giants who were generous with their knowledge. They did not put a patent on a technique, they published it, and they allowed us to use that technique by allowing us to improve and modify on them. So this has been since the time of Sullivan and Atkins in '68, going all the way down to the various modifications over the last several years. Further contributions, a lot of people remember when Henry introduced the zigzag flap for having papillae between the implants, all the way with Channel-Ax microsurgery and Palacis interimplant papilla, second stage exposure technique, and Tom Wilson down in Dallas when he explained the benefits of enamel matrix derivatives with the angiogenesis along with the work of David Cochran, and then Homazada's Vista technique. One thing that stands out is growth factors that we started with PRP going on to Anitwa's PRGF from Vitoria, Spain, and more recently both IPRF and APRF, and we're all looking at stem cell regeneration, with some of the microsurgery techniques modified by Hertzler to be done also without the microscope. So when I look at growth factors, I am just like most everybody in this room. We can't stand having a new technology in dentistry without just jumping and buying it and getting it. We're just technology freaks. So when PRP came out, I went and got the machine. When I heard of PRGF and Anitwa had dinner with me, I went and got the system, and now IPRF and APRF. The question is, growth factors. Do healthy patients really need them? Do healthy patients really need them? Or are we trying to cover up for a sloppy surgical technique? If you're careful, if you're respecting the tissues, you're going to get the same results you're going to get with growth factors or without growth factors, in my opinion. In my opinion, I remember in 1996 visiting David and Maurice when their practice was on West Paces Ferry Road in Atlanta. And David asked me if I'd like an espresso, and he told me I'm going to put in a very fancy coffee table. And that coffee table was a laser unit that they had stopped using because they had bought it and found that it wasn't delivering the results that they were really hoping. It works, but it's not really that dramatic. So I'm still in the process of discovering all this and looking back at my patients. So what I thought to myself, when I got asked to present at this meeting, I thought, why don't I go back and look at my own experience? Is a good blood clot all we need in a healthy patient? Now that we have the socket shield technique, we're using the patient's own hard tissue to protect our bone and implants. So I decided to let my own experience be the judge, and based on that, I'm going to present to you some cases that I've been doing over the past 20-some years. So let's look at some cases. Now remember, this is from the last century. Believe it or not, the 90s are in the last century. So now I'm looking at that, and here is what I presented when I was doing cases in the early 90s. As far as careful and gentle extraction technique, with partial extraction therapy being the new thing today, meticulous socket debridement, good blood supply and marrow penetration, having the dehiscence or fenestration in immediate implants that's not more than 1/3 to 1/2 the mesiodistal distance, so you don't end up with a problem. Adequate bone apical to the implant. Back then the philosophy was 4 millimeters. Now we have different concepts, placing the implants more towards the palatal. Good implant stability, minimal pouch reflection if you're going to put a graft, so you don't deprive the thin buccal plate of its blood supply. Precise placement of the soft tissue graft and trimming of the barrier, so you don't have a messy looking surgery. No pressure on the graft from the temp. Ovate pontic designs and undersizing the uncovering incision at the facial half, and most importantly, when we build the restoration, avoid the facial, cervical, and subgingival over-contouring, so we avoid marginal recession, and then communicating with the lab. So when we take a look at this, and we look back 20-some odd years later, has much changed? The concepts are there. So I decided to go and look at a few cases which I'd like to share with you. This is Jim in 1999. He presents with a root resorption and a facial bone fenestration. Back then we used axial tomography because we didn't have computerized CBCT scan at that point in time. Well, Jim had trauma a long time ago, and the tooth actually that had the problem was number 9, not number 8. And you can see where the apical fenestration was and where the proximal fenestration was and resorption. This means that you have bone loss. However, we had enough bone to place an implant, so we placed an implant. We placed it towards the palatal. We did our homework and filled the facial aspect of the socket, and we added a soft tissue graft. And this was way before some of the studies had come out with placing the xenograft over more coronal to the implant body and placing the soft tissue graft. So the concept has been around, and it seems like most of us on different sides of the oceans are thinking alike. We take a look back 17 years later, and this is what we see. Here's the implant, and here's the soft tissue. It's been maintained. There's not much difference. And so this is a philosophy, and we think that nothing really changed much. When we have adequate soft tissue to stabilize the implant and gingival support, we may put the connective tissue graft to maintain the three-dimensional topography, and we'll use an ovate ponic or immediate temporization, which really has been advocated a lot. But as Dr. Park said this morning, there are some cases where you're taking a higher risk, and in private practice, we all want to go home and sleep comfortably. So when we're comfortable with those cases, we'll do them. Sometimes we'll have to stage them. So I'm going to give you some clinical scenarios in young adults that I was able to follow over the years. And it's nice to have this group of patients and be in a city where it's a small, big city. And they don't call it the Big Easy for nothing. People are easygoing, and they are nice. We can follow them over time. So let's look at a couple of cases. This is Michelle. Michelle is a very sharp girl. She's a 4.0 GPA. She came to me when she was just starting college, and she was on her way to MIT. And her parents said, you know, it's time to consider something for Michelle, because she's been wearing this retainer for quite some time since she had the orthodontics. Michelle, being a very sharp girl, and both parents are doctors, was thinking ahead. She came to me and she said, I know that the technology today will be outdated in 10, 20 years. So I would like to have something fixed because I'm going off to college, but I want also the choice of not having my aesthetic rehabilitation be irreversible. So I agreed with my dentist that I am not going to have my teeth filed down. I'm going to have composite restorations, even on the implants. So I said, okay, I'm the surgeon. I'm just the surgeon. The dentist is in charge of the treatment. So when we take a look at this defect that she has, it's really a minor one. It's a class 1 defect by Siebert's classification, which Alan called type B with the buccolingual defect. And it's a minor defect in the essence that we know we have enough bone. And this is something that may or may not be noticeable, but the patient does have somewhat of a high lip line. So we did the usual. We've learned different flap designs, and one of the designs was not to drop verticals. And if you do that, you got to be careful, because when you fill in that area, the flap will retract. So you have to release it at the apical area, otherwise you'll end up with recessions on the line angles of the adjacent teeth. So I did what I learned at the time, the best of my knowledge: bone graft, resorbable barrier, and then I noticed I still couldn't get that dip to look better, so I placed connective tissue graft. One side of the palate, divide the graft in two pieces, and simply layer it on top of the resorbable membrane. This was done in a two-staged approach. So we used the retainer that she had to create ovate ponic designs, and this is the outcome of a removable ovate ponic design. And as we know, that the bone is dictated by the shape, by the size, by the level of bone on the adjacent teeth, from the article that was published by Team Atlanta back in the late 90s. So this is Michelle 15 years later. And what about the long-term bone support for the connective tissue graft? What is the mistake I made over here? Is that I used an allograft. I wasn't familiar with the socket shield technique, and I should have used a xenograft, which holds the space much more. So when I look at this, yes, it looks okay. The composite restorations are okay. Aesthetically, there is something to be desired, even though there's still a little bit of translucency, but they're holding, surprisingly. We did a connective tissue graft at the first stage, an ovate ponic site preparation, but we've learned from this that we want to consider some type of particulate bone graft that stays, rather than something that may turn around a lot faster and cause a depression over time. Now, this is Elizabeth. Elizabeth is really a wonderful young lady. I've known her since she was 10 years old, and we started this case years ago with both Jerry Sheesh and Mike Block. And Elizabeth inherited her mother's problem. Her mother was Jerry's patient, and she had the same anodontia problem. But in Elizabeth's time, implants were an advent. In her mom's time, they were still in their infancy. So we can see that she is missing some permanent teeth, and we had to manage the space orthodontically and correct the occlusion while her facial growth is developing. So this is Jerry preparing the case, and he's taking his facial index in order to create a mock-up of where the teeth would like to be, where he'd like the teeth to be, and where the veneers would be, where the restorations would be, where the implants would go. We were also cognizant of the fact that in some areas the bone was extremely thin, would require a lot more surgery for that young lady, and we decided to go with cantilevered pontics on implants. So the plan was to place a couple of implants on either side and cantilever the pontics along with facial veneers and maintain the space until facial growth is complete. When this was all said and done, Mike Block comes to me and he says, you know what, I really like you to augment the soft tissues. And I told him I have a technique that I think may work for her. It's the onlay graft by Siebert that was modified by himself from 1988 to 1996. And this is interesting because Michael Orth was an LSU grad, published this technique in the June article of the Journal of Periodontics and Restorative Dentistry without knowing that Siebert was accepted for the August issue. Exact same technique. It's mainly an onlay soft tissue graft with a connective tissue tail embedded inside the pouch. So we did that, which allowed us to create somewhat of an ovate pontic site in this very thin ridge area. There was a couple of block grafts that had failed on this patient when Mike had done them, and he told me the blood supply was just impossible in that area. It's all about the blood supply. So we opted to continue with the plan, and this is from 1994 to 2004. So this is Elizabeth now at final restoration delivery. It's interesting to see the facial growth, and Maurice being double qualified with orthodontics, he's the one that delivers treatments like this all the time. For me, this was quite a landmark case. And it's nice to see the patients after a long time when we do an interdisciplinary approach and when we consider using an onlay type connective tissue graft before the second stage so that we can use the ovate ponics to create the site that we'd like to create. The interesting thing is that during the course of treatment, Elizabeth fell in love with dentistry. And she decided that she would like to become a dentist. So to go to this week, this is Elizabeth this week. She came to my office with her husband and new baby, and she's now in my Spear Study Club. So it's really wonderful to see a child who's grown and has maintained their smile with a technique that soft tissue grafts have helped us maintain over such a long period of time. It's really quite rewarding when you think of the human being behind the mouth. Kevin came to us in 2003 with a traumatic injury, nothing you all don't see every day. One thing about him is that the facial plate had about a little bit over half the mesodistal distance of dehiscence, but I had plenty of great bones, so I decided at the time I was a little bit more adventurous than I am now, placed the implant. So I knew I'm going to have to build that area and augment that dehiscence. So the membrane is placed. This is a resorbable collagen membrane that's stuck to sit barely on the intact bone margins. And once that's done, we place in the xenograft to maintain the space, and then the soft tissue graft, the connective tissue graft, is done in the classic manner that you've all seen in order to support that soft tissue margin and prevent it from receding. However, we need bone foundation for that soft tissue graft. So when we come back and look at the case at the time where we did not have zirconium abutments, this is how it turned out. And this is the emergence profile, and I cannot come anywhere close to the cases that Dr. Campos showed today with the socket shield technique, but this is probably as close as I could get considering how far back we started this case, and not even with a zirconia abutment, which was not available at the time. Ryan came to us in '96 following a motorcycle accident with complete loss of the facial plate of bone. In this case, we had to go to autogenous block bone grafting because of the size of the defect. We all know from the studies by Buser in the Journal of Oral Maxillofacial Surgery and some follow-up by Henry Salama that we get somewhere between 23 and 33% shrinkage of the block graft in some situations. So this is the best we can do with a block graft augmentation. So while we were still looking at the tissues and waiting for the integration, we decided to add a connective tissue graft to enhance our emergence profile and make sure that we have enough of an aesthetic outcome in the end. So this is the connective tissue graft being placed in interpositional manner in order to enhance our final outcomes. And now you can see this is where we started with the block graft and the difference when we added a connective tissue graft. So yes, am I using the connective tissue graft a lot? I am. Do I like it? Yes, I love it. Will I use it compared to some other techniques? Most of the time, yes. I would consider a modified roll and other very nice techniques that are out in the literature, but in my hands, this has worked quite well. Peggy came to us in 1995 with this problem, and her request was, I've been like this all my life, I now would like to have a Hollywood smile. Well, when you have a patient that gives you that specific request, it becomes one of those situations where you have to take a couple of steps backwards and then look at what is the problem. Especially, she had some financial limitations on treatment, so we had to treat one arch at a time, and she never really could afford much aesthetics on the lower arch. So these are the missing teeth. And when we started, we wanted to do some space management. So what happens when you open the space? You flatten the soft tissue topography. However, we are relying on the bone on either side to keep the height of the papilla on the adjacent teeth and hence on the future implant. So the plan is to have an implant in this position. These are the deciduous teeth. The plan is to have maybe one implant here or cantilever. However, she said, no, I want 2 implants to replace those 2 teeth. So when we look at this, Can we work with that? The answer is yes, we can work with that. So we're going to create an inter-implant papilla by simply maintaining what we have. So why not take the teeth out, remove the roots, and use the orthodontic wire in order to maintain this papilla that we have. She also was concerned about the final outcome, so Jerry Sheesh wanted retrievability, and with the curvature of the premaxilla, we had to place lingual set screws for the retrievability of the product in case she doesn't like it. So 3 veneers and 3 restorations on implants. This is 95 and this is 2016. So if we look at it, this is as close as we can get when we don't have a tooth. This papilla came out very nicely. These are the natural papilla. And this is not a central lateral dilemma, it's more of a lateral canine dilemma, but because it goes to the corner of the mouth, you may not see that the papilla is a little bit higher, which averages about the 3.5 in the multi-center study that Salama and Tarnow had published on the interdental height of the papilla, knowing that in that study the range of height was from 1 to 7 millimeters. So we had cases that had 1 millimeter and cases that had as much as 7 millimeters, so it's really case dependent. So when we look at this, we see that the papilla regeneration was possible at number 7 with an ovate ponic, and papilla maintenance was possible between teeth number 10 and 11 by simply maintaining what the deciduous teeth had established for us from the get-go, except that at the time of extraction we used the ovate ponics to maintain the space. This is Kendall. Kendall is a pre-med student, and her aunt happens to be the hygienist for one of my top referring dentists. I've known the aunt for such a long time. She temped for him as a hygienist on a few occasions about 15, 18 years ago. So when her niece was ready to have some work, she was living in Baton Rouge at the time because she was going to LSU in pre-med, and she was working as a part-time model to support herself through education and pay for her medical school. When we looked at her, she came to me and she told me that I have a problem, and the problem is the photographer who's doing the photo shoots for my photography is asking me not to smile so high because I'm showing a gray shadow up here which he doesn't like. Yes, he can Photoshop it, but he just doesn't like the curvature. If we really look at Kendall's problem, it's more of a skeletal problem because she had a narrow jaw curvature, and in order to give her a nice alignment for the teeth had to be moved outside the envelopal bone. And when that happens, we all know, experienced people who have seen that the teeth look like they're flared out a little bit, which is what we're seeing over here, even with all the beautiful veneers that she had done on some teeth, and some natural teeth were kept the way they are. So here's the x-rays I got, and then I looked at her, and then this is what we're looking at. It's not just a problem of color, it's also a problem of tissue level. And if you look at the CBCT scan, you see how the teeth are a little bit prognathic or protruded somewhat, which is the problem you have when you're placing a soft tissue graft and you're now dealing with a plane of restoration that's a little bit too far outside the envelope of the bone. However, it was possible to use a mucograft. She didn't want us to use her own tissues, and coronally advance it and get the result that we looked at over here, which was more accept. She actually loves it, and her photographer is happy about it. And she's had the self-confidence now to go and do more photo shoots. So now you look at these people, and if this is your daughter, if this is your sister, you would like to see them have that confidence, especially if this is a serious person. This is a person who wants to become a doctor. She is doing modeling because she wants to become a doctor. So you want to give her the confidence because that's her source of income. She made it on the cover of the Bridal magazine, and since then her photographer was so impressed with the outcomes that he's been using her more and more. And she actually sent me those pictures just 3 days ago when I told her I'm presenting her case. So she told me, let me send you some of my more recent pictures. She's now a medical student. She's got a couple more years to go. So I think she's going to be an outstanding person. So now that we've discussed the philosophy, I'm sure some of you are asking for technique. In the interest of time, I have about 3 minutes. I just wanted to show you an article that was published in 2006 of most of the cases that I just showed and some more. So if you'd like to review that article, I have step-by-step technique with colored photography in the article, including some of the slides that I didn't have much time to show with the block bone graft on the case that I showed earlier. So here are the cases, and if we look at them, not bad considering this is 22 years later. We didn't have the technology on some cases with zirconium implants. We didn't have CBCT scans, but we had tomograms. We didn't have the socket shield and partial extraction therapy. However, when we look back, did we go home and sleep well? Did we try our best? We certainly have. We know we can always improve. We can make it better. And with that, I'd really like to thank you very much for your attention.